All right, good deal. Well, thank y'all, and appreciate y'all making the time and having me speak and being able to work with our thoracic surgeon colleagues. Again, I'm not a surgeon, so traditionally I can't cure your lung cancer. I can't do radiation to it, and I can't do surgery to it. But what I can do is, again, I'm usually the first point of contact when it comes to patients having a spot on their lung, and I can help with treatment modalities, help our surgeon colleagues. And I kind of want to talk about an example of that to begin with. This is a patient who came in with a tiny nodule. I put a little circle around it to be able to see it. It's very, very small. It's about the size of a top of a pencil eraser, so pretty small. He came in. There was a concern that this was cancer, so we went in with our robotic bronchoscopy platform. We diagnosed it as lung cancer. We actually put the patient back and took him again for the patient. Then went to a surgeon to get evaluated for surgery. Was a surgical candidate. But the fact that this is so small, the surgeon wanted a little more localization to be able to resect only the area that houses the cancer, not have to take the whole lobe out. Again, like Dr. Pettiford said, taking as little lung as possible while still taking out all of the cancer is paramount to your survival and to not to leave you with good lung function. So we did something called a dye marking for our surgeon. This is the intraoperative image of our needle going into the lesion, and we have advanced imaging with our robotic bronchoscopy platform, and we can really be more accurate knowing exactly where that needle relationship is to the lesion. You can see the white is my robotic bronchoscopic arm, and the needle is touching the tip of that lesion. That gives me confidence that I'm sampling where I'm supposed to sample, and I'm not missing. And because this thing is so small, it can be very challenging to get to that location and confidently sample that lesion. If the biopsy comes back as cancer cells, then you know for sure you got it, and there's no question. If the biopsy comes back as benign tissue, well, either that lesion is benign and it's not cancerous, which is great news, or unfortunately, maybe I missed, and we got non-diagnostic material, and the patient still has cancer, I just could not diagnose it. So having an accurate and timely diagnosis is extremely important to getting the next step of your care. This video did not work, but I'll illustrate it for you. It's a robotic arm going up, and there's a tiny coil that I soak with a dye that lights up on Dr. Pettiford's surgical platform. And what I do is, after I get to that location, I confirm my location with the CAT scan, and I deploy that dye-soaked coil. That way, when the surgeon goes into the operating room, it can light up for them, and they can carve out only the area that they have to. This is an intraoperative picture Dr. Pettiford knows very well. This is what it looks like on his machine. You can see the robotic arm coming in. The lung is on the bottom there, and that green dot, that tiny green dot the size of a dime, is where he would have to go in and surgically and accurately remove. And that's where the cancer is housed, because I was able to place a dye next to that nodule, and our surgeon was able to go in and remove that, and the patient, again, went home in a couple of days being cancer-free. Other things I can help with, and just like Dr. Pettiford said, the goal would be that everyone is a surgical candidate. Everyone can get cured for their stage 1 lung cancer. We're not there yet, unfortunately. People come in at later stages, stage 3, stage 4, and oftentimes what happens is when they come in, they have tumor not just in their lungs, like Dr. Pettiford said, but also in around their vessels and in their airways. And think of me like a glorified plumber. Right? If there's a blockage, I go in and I try to unblock that blockage. Typically, you'll come to me and saying, I'm very short of breath, I'm wheezing, I'm having difficulty breathing. We'll get a CAT scan, we'll see a lesion or a blockage in your airways. And because of that, I can go in and open that up. That'll give you more energy, be able to walk further, do better, and have better functional status, and that'll set you up to being a candidate for further therapies. Often, if you're too sick, you're not able to get any therapy. My goal is to get you more healthy and breathe better so you're able to undergo the actual curative therapies that our colleagues can provide. There are 3 types of obstruction in the airways. One is intrinsic, meaning the tumor or the lesion grows inside the airway. Next is extrinsic, meaning there's a tumor, like Dr. Pettiford showed that last slide. It is a tumor outside the airway but squishing the pipe. Right? So narrowing the pipe and you still can't breathe, but the tumor is not, I can't see it when I go inside, but it's still causing a lot of issues for you. And last but not least is a mix between the two called mixed disease, where the tumor is outside and kind of erodes through the airway. There are different ways to approach these, but all of these can be navigated and managed for the patient and giving them significant symptomatic relief. One of these ways is placing a stent, and just like a stent in your heart, it can be a stent in your airways. Unlike a stent in your heart, these are not meant to be lifelong. They're meant to make you feel better for the time being, get therapy. Then after that tumor shrinks and goes away, the goal is to get that stent out as soon as possible, not to cause you any long-term effects. We have multiple materials that we can use. One is silicone, one is an alloy called nitinol that we place, and they're kind of inert and don't give you too much difficulties breathing when we place them in your airways. But again, they're meant to come out when you don't need them anymore, as you're able to get therapy and work your way toward cure. So here's a patient that was very special to me, very interesting patient when I first started out, kind of my first 2 or 3 years as an attending doing this practice. He came from Lafayette, Louisiana. He had left-sided lung cancer, a lot of cancer in that area, and the surgeon at that time, many years ago, decided to take out the entire left lung. He was cancer-free for many years, and then unfortunately came back to my office feeling very short of breath. What you can see here is here it is. If you can see right here, this is the main windpipe, the trachea. I'll show it right there as well. There's a large lesion encompassing most of that trachea. So obviously the main trunk of his tree is blocked off by disease, making it extremely hard for him to breathe. We ended up taking him for bronchoscopy, not to be squeamish, but this is the intraoperative image. This is the main channel that you breathe from. On the left, that little sliver of black, that's where he's breathing from. So probably around 90-95% obstruction of his airway. He was still feeling pretty well. He was a very kind of salt of the earth kind of guy, didn't really complain very much, right? And afterwards, we're able to remove this, and this is what it looked like after. So you can see now, obviously air can now get in there. The clog was unclogged. I did a good plumbing job where I removed the lesion, and I burned away the area or the stalk where that was growing from. And the burning looks a little worrisome now, but you come back 6 weeks later, and it looks pretty much like nothing was there, right? Thank you. Anything. Okay. Thank you. So this patient, again, I didn't cure his cancer. He had, metastatic disease from his old cancer, but I gave him the opportunity to go and get radiation to that area and able to get treatment to that area. When before he was not able, he couldn't lay down, he couldn't walk more than 10 feet, he couldn't really live his life at all. And now he was able to be a great candidate for radiation therapy, and he's still doing well. So I'll show a few other examples where patients come in. Right here, I'll give you a crash course right there. This is, again, the main windpipe. It is very squished by disease all around the windpipe. This is not a surgical candidate, as the disease is kind of everywhere. I'll show it again over here. This is what it looked like inside. Very lumpy, bumpy, not smooth, very angry. The patient was significantly short of breath, again, from that main tree trunk causing difficulty breathing. This is after stent placement. You can see the lumen is much larger. Again, opening up that pipe so now they can breathe and feel better and hopefully continue their therapy. This was a patient who had to come to the ICU, was not feeling well, had to be put on a ventilator because they could not breathe, and was able to be extubated, or the ventilator was able to be removed immediately after the procedure, and they went home the next day back to their hometown to get treatment by their oncologist. Here's another one. I remember this patient very fondly. She, again, is from a small town in Louisiana. She had a sliver of a major windpipe as well. She came in, again, on a breathing machine. She was a little older, and we ended up taking her to the bronchoscopy. So after discussion with her and her family, that she wanted to proceed with more aggressive measures. This is what the inside looked like. Again, very angry looking, very oozy, very friable, easy to bleed. Ended up placing a stent as well. She, again, was taken off the breathing machine. She was able to go home. And again, she had a small cell lung cancer, a terrible form of lung cancer with a bad prognosis. But because of this, instead of having a difficult conversation and not having any options for her and leaving her on the breathing machine, we were able to get her extubated. She went home. She was able to cook Thanksgiving and Christmas dinner to her and her grandkids, and then passed away a few months after that. Again, I'm not treating the disease, but I'm able to give her more quality of life and let her be able to spend more time with her family and do what she wants to do. So one thing I wanted to also pivot to is something newer and is very experimental right now and a newer technology. And these are cases where patients are not surgical candidates, meaning they cannot get cured by Dr. Pettiford, cannot get cured by a radiation oncologist. They are unable to get surgery, unable to get further radiation, and this is more of a salvage therapy that we can offer. Again, it's very experimental, so we don't do it in every case, but if there is an instance where you've exhausted every opportunity, then I'm happy to try this for you. We have a couple quick things, different ways we can do it. We're still trying to figure out the best modality to do this, and again, that's why it is experimental. We have a couple of clinical trials with us in doing these procedures in patients, but the main couple things is, one is heat therapy. You go ahead and burn and zap the tumor away. The most common practice now, and the one that has the leading modality, is microwave ablation. You just kind of cook the tumor in that area. It uses heat to kill the tumor. The problem with this is it's nondescript. It uses heat to kill whatever the catheter is next to. So blood vessels, things like that can be a little dangerous. We're still trying to work through that and figure out the best modality. We have a new catheter that I'm using currently that is fairly safe, but again, we need long-term data, 5-10-year data to see how that does in the future. People thought, well, if heat is too excessive, why don't we try using cold therapy? And that's cryoablation. We use a freezing probe to get things less than 0 degrees Celsius, very, very cold for 5, 10, 15 minutes to try to kill that tumor off and hope the tumor dies. This is favorable. It's working well. It's also safe for the blood vessels and safe for the structures in your body. We don't have long-term data to see how well the tumor may die off. We want to make sure we kill every last cell, and we don't have that long-term data yet. Third is something called photodynamic therapy, and what that is it's a bit challenging, I think, in Louisiana personally, but it can be easily done here. It is a material or a medicine that you inject into your veins, and what it does is it makes your entire body very sensitive to sunlight, which can be challenging in Louisiana for all the hunters and the fishermen here. But what we do is we have a catheter that has a very high intensity laser on that area, and we stick that laser into the lesion with our robotic bronchoscopy platform or our bronchoscopic platform, and we shine that light for about 10 minutes in that lesion. That lesion will be, very sensitive to the laser light and will die off. Last but not least is something recently came out, and really there is not a lot of data, but we're working toward trying to figure out best modality, something called pulse electric field therapy. What that means is use mild electric pulses to denature the cancer cells. They release antibodies, et cetera, and the body can refight the cancer. It kind of re-energizes the body to thinking the cancer is foreign again and can attack it with a combination of immune therapy and or radiation. So there's a lot of great things. We're on the cusp of I think, a breakthrough in the next 3 or 4 years. I'm very excited to help out with that. And again, these are patients where, not patients who don't want surgery. These are patients who cannot get surgery, cannot get radiation, and this is the last step of potential salvage therapy. I don't want to misunderstand me and think anyone should not get surgery. Surgery is the #1 way to be cured and the best chance you have at living a long and healthy life. And with the techniques Dr. Pettiford deploys, you're back playing golf in a couple of days. In 2 weeks, you're going to look back at that and be very happy you went through the experience. This is something where surgery is not an option, or it recurred again and we can't take any more lung out, or radiation, you've done all the radiation you can do. This is something we can still give you an option to continue your fight against this disease. So that's it. This is our interventional pulmonology team in our suite, and that's it. If you all have any questions, I hope we take them soon. Thank you.
We have time for just a couple of questions, so if you have one, please raise your hand, and I'll try to work my way over there too. While I'm walking that way, Dr. Pettiford, you told us that if somebody mentions that they want to do an open thoracotomy, the old way of doing things, you said they should run. But is everyone a candidate for robotic surgery, or are there times you still have to do it open?
Yes, Dr. Tuckson, that's an excellent question. No, there are some instances where you should not undergo a robotic surgery. And yours truly just did one of those surgeries earlier this week. A patient had a large mass in her chest. It's something called a schwannoma, which is a tumor of the nerves. The mass was covering her spinal cord, spinal column, covering her aorta, which is the largest blood vessel in the body. I would not even be able to get my instruments into her chest to do the robotic surgery. Sometimes if the tumors in certain locations or are attached to major blood vessels, critical structures, you shouldn't be using the robot. It's a sign of poor judgment.
Thank you very much. Please stand up.
And thank you for being here and all that you do. My question is, as lung cancer treatment advances, it sounds as if we're moving towards sustained control and quality of life, especially because of late-stage diseases. And is there anything that you're optimistic about that will be eventually moving towards cures?
Let's start with Dr. Abdelghani on that one.
Yeah, absolutely. Thank you. So I think it's extremely exciting now with, now it's almost getting to the point where if you are diagnosed with advanced disease, you're almost living with it, much like any other chronic disease. We have all these new therapies that target things, much like antibiotics target certain bacteria. We can do certain mutations where these targeted therapies can target specific mutations and literally have the cancer melt away. And then as the patient, if they progress again, we rebiopsy, redo the mutations, have a different mutation possibly, and can give different therapy. So nowadays, with every year, 2 or 3 new medicines come out, and it's really hard to keep track of, and you can just keep on helping the patient do better. It's really super exciting. I'm very, very excited with the next 5 or 10 years. We're going to have great, better ability to find these mutations and more medications that target almost every mutation you have.
Dr. Pettiford, before you answer that question, would you consider, is it the change in medications that's making the survival rate for patients with lung cancer better, or is it the early diagnosis, or is it a combination of the two?
Excellent question, and you were hinting at a point. It's a combination. It's multifactorial. So you have to hit things from multiple angles. Early detection translates into better survival, period, point blank, end of discussion. But as Dr. Abdelghani referenced these new drugs, and he is absolutely positively right, they're coming out like this. And they are allowing patients to not only live, but have a decent quality of life, which for many of us is as important as living.
We're going to take this question, then one other question on the side. I want you guys to think about a take-home point, one point, but first.
Hi, thank you guys for the excellent presentation. So I'm an internal medicine physician myself. I'm also a stage 4 lung cancer survivor. I was diagnosed 9 years ago. Now, when I was diagnosed with locally advanced disease. But now they are talking about local consolidative therapies. So what is your opinion on that? And how do you see that coming more into the fold to help, stage 4 lung cancer survivors that don't have to now deal with residual disease?
But first, describe what local consolidated therapy is.
Sure. First of all, I'll tell you like I told the folks yesterday, I congratulate and applaud your courage as a lung cancer survivor, and you have the experience of being on both sides of the fence as a healthcare professional and as a cancer survivor, so kudos to you. We're doing that now. Consolidative therapy, local therapy, we're doing it. What she's talking about is the use, these patients are not surgical candidates, but we need to have a means of treating the main site of cancer, and it's a combination of chemotherapy and radiation therapy. And then you will use drugs like the targeted therapy or the immunotherapy to treat the disease that's kind of left the main site or ground zero. And so we're actively doing that. We discuss that almost every other week in our tumor board. And that's the medical oncology doctors, so the chemotherapy doctors and the radiation therapy doctors are the ones that kind of spearhead that treatment. So it's here.
Did you want to add anything to that, Ramsey?
One thing I want to kind of mention on the surgery standpoint, they're doing things where you'll give medication or chemotherapy or immunotherapy before surgery to make the surgery easier and to almost downstage the patient, right? If they're stage 2, it may go down to stage 1, making a better surgery and to kind of clean up everything else that could be everywhere else. It's been incredibly amazing that our technology has advanced so much and we can really treat all these patients, and it's not a death sentence anymore, right? Now it's completely changed in the past 10 years when now you say, oh, he had lung cancer. No, he has lung cancer. He still has lung cancer. He's still living with it, and he's doing well.
Thank you.
The machine that goes in and does that for you, is there a degree or how small or how big the lesion or nodule or whatever needs to be? I have 2 new ones in my left lung. My cancer was in my right lung. My oncologist tells me they're less than 2. He gives me numbers, 2, 3, the size, and we keep doing 90-day scans to see if it's growing before he can do that biopsy. And I want that biopsy now.
So she really addresses the point. You tell somebody that they have a cancer, and you're going to tell me to wait and watch it? I don't think so. That's a big cycle. May not make a difference. Tell us, what difference does it make in terms of growth?
Yeah.
And is it the psychological factor, or is it something physical?
So I completely agree. And then the problem is, as Dr. Pettiford talked about earlier, not every spot on your lung is cancer. And the challenge is, so the smallest we've ever done right now is 2.5 millimeters, but it doesn't mean we can. It's all, we can do anything. The thing is, should we, right? We're putting you through the procedure. Is some risk to the anesthesia, risk to getting the biopsy, correct? So 2 to 3 is, the problem with this is, and I tell my patients the same thing, I get the exact same exact same question. 2 to 3 is, it basically, the radiologist has to manually measure that. And if you measure it together, I could move my hand a little bit, my hand could be a little shaky, it could be from 2 to 3, even though the nodule has not changed in size.
And may I add that if you will hold on to that thought, not the session that's coming up, but the one after that, we're going to have Dr. Abdelghani speak again about how artificial intelligence helps narrow this down a little bit. So I think you're going to get a little bit different answer after that session, if I'm not speaking for you. All right, gentlemen, please. I'll start with Dr. Pettiford. What is the one take-home point that we need to have coming out, that you want us to take from your presentation?
Almost the first slide from yesterday's presentation. You have a lung cancer diagnosis, take a deep breath. It's 2026, it's different. We have treatments available that are effective, but we also focus on your quality of life. There's hope.
Dr. Abdelghani.
I completely agree. And every step of the journey, from diagnosis to treatment to, God forbid, recurrence, we have new therapies, new techniques, and a multidisciplinary approach. Many, many physicians on the team all can offer something to you. And some patients will tell me after diagnosis, I don't want to get surgery. I'm like, it's different now. Sit down and just talk to a surgeon. Have him or her explain to you how it's done, and then you make a decision.
And I want to tell you one other thing. Dr. Pettiford made a point of saying that this is not the treatment we had in the 70s, 80s, and 90s. The reason why this is not the disease that it was in the 70s, 80s, and 90s, and those prognosis for patients, our sponsors of this program have made significant advances in the pharmacomedics of treatment of these patients that go along with all the stuff we've heard about. And that's the reason why. And it is your being here with us today, being aware of the importance of screening, the importance of early diagnosis, and then working with our pharmaceutical colleagues for these wonderful medications that have changed the whole dynamic, that have taken lung cancer from a disease of us saying, well, I'm sorry, you're going to die, to, as Dr. Abdelghani already said, a disease in which you can live with for a long, long time. Thank you all very much for being with us, and we'll see you for our next session beginning immediately.